So we need innovation. And for innovation to find new drugs, new therapies in our pharmacies, obviously industry is the key player. And as I'm sure you will realize during the talk given by Phil Larsen, Global Head of Diabetes Research and Translational Medicine at Sanofi, industry is now understanding that it should revisit the way it really contributes to innovation. And what we see in IMI is that indeed industry is more and more keen to develop so-called non-competitive research for some steps in innovation, which means that companies are working together. And the other aspect is this aspect of open innovation, which means engaging much more in a much more collaborative manner with the other stakeholders in drug development. So we are very happy to have Phil with us today. You have to know that Phil is playing a key role in shaping the diabetes program for IMI2. So I think it's what you will say will be very important.
I'm pleased to be here. And this morning, I'm going to tell you briefly on kind of providing the industry perspective of drug discovery in diabetes. And for those of you who have patients in the afternoon, you will hear about a more specific, concrete initiative, which is the second IMI. So when we start talking about diabetes, it's obviously really nice to have real sort of input from patients who are bothered by living with diabetes every day. And there are a lot of people who live with diabetes in the world. There's actually more than 500 million people living with diabetes in just a couple of years. And that's also important to think about here, that by applying what we know as the rule of halves, it's not as easy as it is for these young gentlemen here who really have in-depth insight and really know about their disease. More than half of the patients with type 2 with diabetes actually don't know they have the disease. And for half of those patients who know they have the disease, proper glycemic control is not within reach. So there's a lot to do with simple means. There's a lot to do in terms of diagnosis. There's a lot to do in terms of improving diabetes care with existing tools available. But we've also learned from the clinicians' input and from the researchers' input that diabetes is not as easily classified as it used to be. So we have traditionally been dealing with type 1 diabetes, which was the lesser prevalent type diabetes, and the type 2 diabetes, which was by far the most predominant diabetes type. But we probably have to realize that as people are different, genetics are really different among people, also in different parts of the world, we probably need a subclassification of both type 1 diabetes and type 2 diabetes. And this is purely based on genetics. But we also have, and I'll come back to that in a minute, to take into account that people, in addition to their genes, are individuals and they're persons with very different lifestyles, with very different expectations. And that's probably the most, I would say, challenging complexity dealing with that when you are developing new medicines for people. Think about consumer goods. What consumer good is available in only one flavor? Very few. And this is what we really have to think about when we're developing therapeutic solutions for people with diabetes, that they need to come in different flavors and they need to be highly individualized. Unfortunately, and this is where we, as people caring for diabetes, really need to step up to the challenge, and that is to accept that when we're also developing new diabetes drugs, coming in different flavors, that we perhaps should be less stringent in terms of what to expect from these new therapies, because the fact is that developing a diabetes therapy today comes with a price tag north of $1 billion, and that's because it's seen as one type or one size fits all. And that's where we need a much better dialogue with the regulatory agencies, the payers, in terms of understanding what innovation can really be brought forward. So let's start with the patient. We've heard patients this morning, most of them with type 1 diabetes, and this is just an ordinary type 2 diabetes patient. It's a mid-aged, male, overweight gentleman, not exercising a lot, on the heavy side, and with an A1C of 8%. The physician sees the A1C, the regulatory agency sees the A1C, but the patient sees something that's completely different. He's seeing problems, not living up to the physicians, his spouse expectations, he's not really getting into life, he has other issues, and all of these issues blended together makes life quite challenging, but it also makes it quite challenging coming up with, a uniform therapeutic solution that really meets this patient. So what can we do? We have to understand we're not just, we want to put the people with the disease in a situation where they're not really driven, pushed by the disease, but they're actually liberated in the best possible way to really live a normal life, but still with the disease. We know that diabetes is associated with a couple of, or actually quite a lot of complications. When you're diagnosed with diabetes, there's a lot of increased risk. There's risk of stroke, cardiovascular disease, amputations, all the late diabetic failures, and then there's obviously an increased mortality from cardiovascular disease. We know that some of these risks are dealt with quite appropriately when you lower glucose. So if you institute glucose-lowering therapy, you can actually deal with a lot of these comorbidities, but some of them are not actually moved to a great extent by glucose-lowering medication. This landmark study, the UK PDS study, which has a number of years behind it, is actually one of the first attempts to demonstrate that proper glucose management addresses a lot of the different associated risk factors and complications with diabetes. But as you can also tell from the UK PDS study, there are a couple of the risks that are not moved a lot. And with improved glycemic control, with better and better care, we know that some of these risk factors in modern populations, modern well-controlled populations, are actually not moved significantly. We know that proper glycemic control in people with type 2 diabetes, when they're near normalized, their treatment actually does not have any further improvement on cardiovascular morbidity and mortality. So that's where the connectivity between glucose and type 2 associated disease is not really well proven. So coming back to what we're challenged with when we're developing drugs for people and therapeutic solutions, because it's not all about drugs, is to understand which of the risk factors, which of the comorbidities cluster with what types of disease. This is giving you a snapshot of some of the comorbidities we know people with either type 1 diabetes or type 2 diabetes are struggling with. You can tell that lipid management is something that probably makes a lot of sense to address. You have also other things we're not often discussing, but people with diabetes have a clear overmorbidity of mental issues, depression, which obviously also has to deal with all of the control in their disease. There are heart diseases, late diabetic complications, predominantly retinopathy and nephropathy. And when we're thinking about developing newer agents and newer therapeutic solutions for people with diabetes, we're thinking about integrating care and therapeutic endpoints that addresses some of these comorbidities. Because, quite frankly, today there are more than 12 registered glucose-lowering drugs available, so it is possible to provide good glycemic control with some of the available agents, especially if you use them in a, I would say, more intelligent way. So another thing which I think is really important to address is how do we, as patients, see ourselves? How do we, as physicians, see the patients we're treating? Because that's not always a concurrent pattern. So we've done some research, and I'm sure many other companies have done similar research, trying to ask the physicians who care for diabetes patients how they classify their patients. And we've asked the patients how they perceive themselves. So if we start with the patients, they kind of, have the self-perception that falls in three clusters. Most of the patients, and I'm sure the patients we've met today would fall in that category, see themselves as proactive and confident, then they know that they're engaged in their therapy. We have patients who are confused, concerned about their treatment, and not really engaged. And then we have people who are scared, worried, and desperate, who despite trying to engage, are not really managing their disease. It's interesting to see that the physician who cares for the patient has a somewhat different view, because he or she is seeing their patient either as people with age-related diabetes, the classical maturity onset diabetes. They see them as obese, negligent, not really engaged at all, have lifestyle issues. They're young obese who really on a fast, slippery slope because they would very soon develop and have issues with their diabetes. We have the real insulin-resistant patients who are on transition to insulin, the multimorbid, very old patients who have all kinds of disease or diabetes-related diseases. Then there are the 15% who really manage their disease well and who needs very little except for a little encouragement. And then we have compliant patients who, despite very good compliance, are really not meeting their A1C goals, and then the small portion with type 1 and type 2. So if we're asking the physician, what kinds of therapeutic solutions are you really in need of for these patients, a much more complex pattern comes out, and it's not necessarily a therapeutic solution where proper glycemic control is on the top of the list. So for some of the patients, and I don't obviously want you to read all of this in detail, it's just to give you a flavor of how nuanced a picture the care providers are actually having. But you can take, say, the multimorbid patient. There's a high desired outcome, which is to reduce the risk of microvascular disease, glucose variations, hypoglycemia, and macrovascular disease. And this is really kind of the decision tree that the physician is setting up when he or she is approaching the patient. So we've tried to bucket that into three kind of clusters of diabetes care. What should diabetes care really be focusing on? The first, and that's really the basic stepping stone, is to make sure that the patient's glucose is in control. And how can we do that? We can do it with insulins, with non-insulin, but super efficacious drugs, all kinds of devices, and some behavioral therapeutic steps that really improves adherence to whatever existing therapy is available. And clearly, especially for devices and sort of anything that improves adherence, the insulins, especially more modern insulins with lower hypo risk, is a very important component. But stepping from getting glucose right, we want to make sure that modern diabetes therapy does more than just get glucose right. We want to provide that additional disease-focused care that really is important for people with diabetes. And that's weight management, it's macrovascular disease modification, blood pressure, lipids, inflammation, and complications management. And then obviously and ultimately, we should not forget the far-reaching goal out there in the horizon, and that's really to understand the disease, the basic pathophysiological principle of disease that hopefully one day can help us provide better insulin sensitivity for people with type 2 diabetes, protect the beta cells from failing, perhaps even bring beta cells back, and then ultimately reduce the need for even worrying about getting glucose right. And I try to, for kind of in another perspective, in a stepwise fashion, say, what are we doing today? Today, we're really improving patients' outcome by optimizing the current therapies with getting glucose right. On top of that, the glucose plus is really to provide sustainable efficacy and additional cardiovascular benefits. Currently, there is actually not really, perhaps except for acarbose, any studies demonstrating better cardiovascular outcome for a glucose-lowering agent. We obviously, to Life Growth's point, want to understand the disease heterogeneity, the comorbidities, and the late diabetic complications, so we can really take it towards much more individualized therapy. I think it's possible to at least get somewhat closer to that using currently available drugs, but we also need new drugs. And then finally, we want to make sure that we really understand the basic fundamentals of the etiology and the pathophysiology of both type 1 diabetes, type 2 diabetes, and the many other types of diabetes that, obviously exist, to get closer to prevention and cure. But we also have, in all modesty, to admit that this is something that lies far out in the distant horizon. Finally, I want to present perhaps what you could see as a little snippet of what insights to basic physiology can bring in terms of novel drugs for diabetes. Because I think the most important decision to make when you start out on a journey to really qualify a new biological target for a modern therapy is to get this target right. And we've kind of reversed engineered in the pharmaceutical industry from having a drug that worked and then subsequently unraveled the target and trying to understand what this drug did. But perhaps you can turn it around and say, by having fundamental deep insights to the biology, perhaps it's possible to promote a new idea for a new target. And there is, fortunately, besides insulin, one such example from diabetes discovery, and that's the identification of GLP-1, where very firm human pharmacological evidence was provided back in the mid-'80s from good experimental medical studies really infusing GLP-1, mimicking enteroglucagon action, as it was called that time, showing that this is truly an incretin, a gut hormone that addresses not only the pancreas, but also many other target tissues involved in metabolic regulation. We can have, I would say, lesser validation when we start out on the target journey, like we know for PCSK9 in regulation of LDL cholesterol, and we can have a mechanistic rationale, but it's unproven except for an animal model. And this is where, unfortunately, by far the majority of all the diabetes discovery projects have started. I think I'll stop here, and thank you.